Hello, and welcome to Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. This episode features the first of 3 expert discussions on best practices for managing patients with advanced renal cell carcinoma. This episode is part of a larger educational program entitled Practical Application of Immuno-Oncology in Renal Cell Carcinoma. During this podcast, focusing on clinical controversies in selecting optimal first-line treatment, Dr. Elizabeth Plimack from the Fox Chase Cancer Center in Philadelphia, Dr. Brian Costello from the Mayo Clinic in Rochester, and Dr. Martin Voss from the Memorial Sloan Kettering Cancer Center in New York will discuss topics including how to choose between current first-line systemic therapy options, when to consider active surveillance and monitoring, and the best use of cytoreductive nephrectomy for individual patients with advanced renal cell carcinoma. For more information on Dr. Plimack, Dr. Costello, and Dr. Voss, along with a link to the complete program, including a downloadable slide set, please visit the show notes for this episode. Now let's get started and hear what the experts have to say on this important topic.
Hello, I'm Dr. Brian Costello from Mayo Clinic. I'm joined by my colleagues, Dr. Martin Voss and Dr. Betsy Plimack. Today we'll be talking about first-line therapy in metastatic renal cell carcinoma. Let's start off with an initial question that comes up frequently, and that's about choice of therapy in first line. So we'll break it down first by favorable risk patients and then intermediate and poor risk patients. So the first question is, what is your preferred first line therapy in favorable risk patients?
Thanks, Brian. This is Betsy Plimack. I'm at Fox Chase here. And it's actually one of the hardest questions I think we face in clinic because these are the patients with the most options, the favorable risk patients. They can be observed. They can undergo focal therapy with surgery or radiation to kind of control disease and buy time off therapy. But for most cases, we're looking at systemic therapy choice. And for these patients, I typically will recommend a VEGF-IO combo, such as Axi-Pembro or something similar. Martin, what's your approach?
Yeah, hi, this is Martin Voss from Memorial Sloan Kettering Cancer Center in New York. I do agree. For me, for the majority of favorable risk patient, the decision is between active surveillance and an IO-TKI combo. Once I do decide that the patient should pursue active therapy, and there's a whole host of factors that goes into that decision, everything from pace of disease, time from original surgery to recurrence, whether they're symptomatic or not, which is unlikely in a favorable risk patient, and also the patient's perspective and their desire to be or not be on therapy. So once we make a decision for a patient to pursue therapy, I will treat most of these patients who have no contraindications with an IO-TKI combo, typically axitinib plus pembrolizumab. I think there is some data, if we look at the most recent updates to the Keynote 426 study, the Axi-Pembro trial, that would suggest that these patients can do quite well with TKI monotherapy. So I wouldn't fault anyone for treating a patient with single agent TKI. However, given the very high response rates that are seen for these combinations, and my experience that they're typically well tolerated, I tend to treat more patients with combination than monotherapy.
Yeah, I agree. Me too. Brian, would you ever consider just a single agent VEGF in a favorable risk patient? It's something we do rarely, but I do sometimes.
I do occasionally, and those are usually patients who are frail, multiple comorbidities, who I'm afraid of giving combination treatment to. I think that usually allows us to start off at a lower dose and work our way up if the patient tolerates. So yes, I have done it, and I have had some patients in recent weeks, in fact, where I've recommended that because I was concerned about their ability to tolerate combination treatment. So let's move on to intermediate and poor risk patients. What is your preferred first line in that patient population?
So maybe I'll take that question first, Brian. And here we really have two combination therapies to consider in all patients who have no strong contraindication to receiving an IO-based regimen. So we have an IO combination on the market, that is ipilimumab plus nivolumab, based on the pivotal CheckMate 2 and 4 study that demonstrated superior overall survival, progression-free survival, and response when compared to TKI monotherapy with sunitinib. And as a second option, we have the aforementioned TKI IO combination of pembrolizumab axitinib, which also demonstrated superior OS, PFS, and response in patients when it was compared to the same comparator arm, sunitinib, across patients on the Keynote 426 study. Both of these regimens are valid in that in the subgroup of intermediate poor risk patients, both of these very strongly demonstrated superiority over TKI monotherapy alone. And it leaves treating investigators with the dilemma of sort of choosing their favorite regimen. And there's a couple of things that are worth noting and that helped me make my decision. And it comes to the differences in how we see these two regimens perform in comparison to sunitinib very early on. And secondly, how much data we have as to what happens long term. So let's talk about the early on differences between what we found in these trials. So Keynote 426 demonstrated a very early separation of PFS curves for patients in the intermediate poor risk subgroup when treated with axitinib plus pembrolizumab. So it was very readily apparent that that combination of the two mechanisms of action was superior with a median time to response of less than 3 months and curves that separated very early, a high response rate of greater than half the patients, and a failure rate that is quite low. On the most recent update, looking at the waterfall plot for patients treated on the combination, 9 out of 10 patients had some type of regression in target lesions. And what that means is that reliably, this regimen is going to help control growth of the patient's cancer in the vast majority of patients. It's very unlikely to fail early. If we look at ipi-nivo early on, then we see patients who can have fast and deep responses, but there is a subgroup of patients that's probably somewhere in the 20 to 30% range who failed this regimen early, meaning that if you treat those patients intermediate poor risk kidney cancer with a purely IO-based combination regimen, there are some patients that are going to fall through the cracks and that it's just not the right treatment for them. For me, that means if I have a patient whose cancer is fast progressing and I worry about early failure and how they might do if they were to not respond to first-line therapy in these early 2-3 months, I'm more nervous to put them on ipilimumab nivolumab than on IO-TKI therapy with axi-pembro.
Yeah, I mean, I think I agree with everything you said, and the data, thank you for outlining that. It's very clear. We do have a lot of great data in the first line setting to look at. I think for me, I see it sort of more simply. I think axitinib pembrolizumab has great response, PFS. It's durable when you look at the phase 1 data out to 5 years. It's my choice for therapy. I really don't see a role for ipi and nivo in the front line in my practice, and I know this is controversial, unless the patient has a contraindication to a VEGF inhibitor. I know there's some questions around, like, do you ever start with just a single agent immunotherapy? That's interesting, but with ipi and nivo, I just struggle with the high rate of toxicity. And autoimmune toxicity is always challenging to both diagnose and treat. So I tend to gravitate to the axi-pembro combination, especially for intermediate and poor risk patients.
So I do agree that there's more immune-mediated adverse events, especially the high-grade events for the IO-IO combination than for the TKI-IO combination. The data says that very clearly looking at these two trials. But for my own practice, I would disagree that sort of, I broadly apply axi-pembro to all intermediate risk patients. And The reason I don't is because I am very fond of the long-term data that we have for Checkmate 214, ipilimumab, nivolumab. For one, based on the fact that this is older data, the trial was conducted and reported earlier, and we have longer follow-up now, median follow-up, north of 40 months. And when we look at that long-term follow-up, then we can see that there's a notable proportion of patients in the intermediate poor risk subgroup, probably about 30% or more, who remain progression-free long-term, north of 3 years. And what that means is, before I was speaking about sort of the short-term perils of just relying on IO, the long-term promise of an intense IO mediated treatment regimen like ipi/nivo is that there are some patients who do very well long-term and seem to have no progression, and 30% of the population is, a notable subgroup. So that drives my using ipi/nivo still in, quite a few patients in the first-line setting. In fact, in a patient where I do not worry about the consequences of early failure, meaning someone with intermediate poor risk, but maybe asymptomatic, good performance status, not a large burden of disease, and no metastases in sort of nerve-wracking locations, I prefer ipi/nivo based on the fact that we have this long-term stability, which has not been reported yet for IO-TKI. And I should say, it may be that we haven't seen it for TKI-IO yet, and we will see it in the future, because as I said, the active pembro data is just a bit younger than the ipi/nivo data. But while we don't know, I don't feel I should deprive patients of sort of the opportunity to be exposed to this highly active regimen.
Brian, how do you look at ipi/nivo versus axi/pembro?
So I think I'm sort of middle of the road between the two of you. So maybe I'm a tiebreaker here. So I have a healthy respect for the toxicities of the combination of ipi/nivo, and in my experience, they can be really devastating if people get significant toxicities, immune-related toxicities, and really set them back. So here's how I've thought about it. I don't offer it to patients in their 70s and 80s. I think hard about it in the 60s. You'd have to be really fit to get it in your 60s. I do prefer it though in patients who are younger, because then I feel as though it helps me keep in reserve pembro-axi for down the road. Again, just my practice style, but I tend to use it only in patients in their 40s and 50s as first line, and beyond that, then pembro-axitinib is my preferred. And I was honestly very excited when pembro-axitinib was FDA approved, because it sort of mitigated some of my worry about using ipi/nivo in older patients. So if I can shift gears here a little bit, two topics I'd like to cover before we wrap up. One is to revisit something that Betsy mentioned about observation. We could talk a little bit about who are the patients in first line who you observe as a preferred first line strategy, if you will.
So I think that's actually one of the hardest questions, because you have to take into account what the patient wants. You have to have the courage not to start treatment. It's always easier to kind of just pick a treatment and start per the guidelines. You have to make sure none of the lesions are in a threatening spot near a spinal cord, near something where even a little bit of growth could cause a symptom. And, time off therapy or buying time till you have to start has to be of value. There are two ways I see it as of value to a given patient. One is they have comorbidities and they don't want to risk the toxicity until they have to. And the other that I tell patients is that, if we can keep you on observation for a number of years, we will know more about the first line. We will have the answers to some of the questions we were just debating about ipi/nivo versus axi/pembro. And so you're always, in a way, at an advantage being treated later on the timeline of drug development than earlier. And those are the topics that we cover in what's typically a very long conversation when we're considering observation.
How do you think about that, Martin?
So I agree with everything Betsy said. It's the process, I feel like, making the determination to start out a treatment regimen is, pretty, there's a definite moment where you say, now we go with oxypembro, or now we put the patient on pazopanib, and here they start, and that's what they're going to do for now. Starting someone on active surveillance is sort of a process that can, drag out, not necessarily in a negative way, over a few months. So oftentimes, if I'm seeing a patient who meets the criteria, checks those boxes that Betsy went over, I introduce the idea of active surveillance, and I tell them, well, why don't we do another scan, and then we make a decision and outline a treatment program that we might choose if we were to do systemic therapy, but explain to them why it is that active surveillance may make sense. And I find that helpful, for one, because it gives me another scan to feel reassured about the pace of things. For some patients, it's crystal clear because it took years for them to recur, but for some patients, it's not so clear. And then secondly, you can also see how the patient does with active surveillance, because it's, for most patients, it's a good thing. For some patients, it's really causing them sleepless nights and they just can't do it. So, so oftentimes the plan sort of evolves over, 2 or even 3 scans, and you see that the patients get more comfortable with it. Now, and then secondly, there are some formal sort of criteria that can guide things. The one study that is commonly quoted and that we all have talked about in the past is a prospective study that Betsy participated in, also that was reported a couple of years ago, and looked at patients who were managed on active surveillance, and just went to see how they did with their gynecology-oncologist, and as a secondary analysis looked into certain factors that may have correlated with longer time on surveillance. And it looks like the IMDC risk score is helpful, and also the distribution of disease, how many organ sites are involved. So I actually do use that quite a bit, and I'm less enthusiastic about active surveillance in patients who have, albeit small volume disease and multiple organ sites. I steer those patients more towards active therapy. And then I do calculate the IMDC risk scores in patients with low scores, specifically those less than 2. I feel more comfortable watching. So I find that helpful, and it's also helpful to give patients some hard data to say, well, here, look at your scores, they're very low. This is all reassuring.
Yeah.
Great. Thank you for that. Was very helpful way to think about things. And I would reiterate that I think that really patient selection in terms of their ability to be comfortable with surveillance is really important. I tell people that even if medically it seems to be a good idea, it's not always personally the right idea for a certain patient. So we really have to take that into account as well. So the last thing I'd like to cover in this session is the issue of cytoreductive nephrectomy, an area that's percolated up again as having more controversy and debate in this field. So I'll start with Dr. Voss on this one. Talk about, when is it that you select a patient to consider a cytoreductive nephrectomy?
Yeah, so that's a very important question, and it does come up for quite a few patients in the intermediate poor risk space who present with what we call de novo metastatic disease, meaning they're diagnosed and the primary tumor is still in place. And the discussion, heated up a few years ago when there was the ASCO plenary presentation and the New England Journal publication of the Carmina study, which was a non-inferiority trial of patients in that very situation who were randomized to either go on sunitinib and not have their tumors removed, or to first pursue a cytoreductive nephrectomy and then go on to sunitinib. And the study, albeit not fully accrued to its original statistical plan, suggested that in the patients treated on that study, patients when outcome was non-inferior if treated with sunitinib and without the surgery. And the authors at the time suggested that caution should be exercised when considering anyone for cytoreduction. And I do agree with that general sense. However, it is very important to think about the Carmina patient population and who went on to undergo surgery. Those were high-risk patients. And to me, the takeaway message from Carmina was that we have to be very cautious about whom we select for cytoreduction. And what I mean by that is some of it is common sense, that patients whose metastatic disease rather than the primary is symptomatic or fastly progressing, putting their systemic therapy on hold while we pursue a surgical endeavor, doesn't make immediate sense, and the data would suggest that it's not in the patient's best interest. But remember that there are some patients, in that setting who have a low volume of metastatic disease. Sometimes they have sub-centimeter pulmonary nodules, or sometimes they, may have, just an isolated adrenal metastases, and may fare well, particularly if they're symptomatic from their primary tumor. So if they have gross hematuria, pain, or even constitutional symptoms that we think are most likely from the primary, given where the burden of disease is the greatest, then those patients, I think, can still be considered for cytoreduction. But the one important caveat there, and this is sort of a rule of thumb that I have for myself, is there are very few patients, who really must undergo cytoreduction that very moment and can't wait the initial few months of being on systemic therapy. So I do think whenever I'm in doubt about it, I lean towards giving the patients a litmus test of systemic therapy and talking to the patient about the surgery as sort of a next step. It doesn't mean that they're not going to have cytoreduction, but maybe they shouldn't have it right away. And maybe they might fare better for us to be sure that we have systemic control before we pursue, a big operation.
Yeah, I think I look at cytoreductive nephrectomy in two scenarios. One, palliative, as Martin suggested, someone with symptoms from their renal mass and it should come out to palliate those. And two, a patient where I plan to observe them after the nephrectomy. And I think in those two scenarios, that's where, in our practice here at Fox Chase, we really lean the most on a cytoreductive nephrectomy. In between, there's no evidence that we help people by removing their kidney, and we should probably promptly start systemic therapy instead.
Do you ever revisit cytoreductive nephrectomy after you start systemic therapy?
We have, but it's always a challenge because if they're on a VEGF inhibitor, you have to hold it till they fully recover, which is always a risk. And two, I think we've seen, as Martin described, really beautiful, durable, long-term results from systemic therapy alone. Granted, many of those patients already had their nephrectomy, but again, I'm just not sure what we're adding by putting someone through a big surgery in addition to whatever nice response they would have had from their systemic therapy. So it's really a data-free zone, I think.
I will say, sort of reminiscent of what we discussed in the context of observation, that there, especially up front, is often a strong desire on the patient's part to have the nephrectomy. So many of my patients who are newly diagnosed with metastatic kidney cancer completely understand that surgery would not be curative, but there's this urge to sort of have the mothership taken out. And I think it's our job as medical oncologists to make sure that they understand the implications of that and to, help them understand that may not always be in their best interest, for all of the reasons that we discussed. But in few patients, it is something that weighs into the decision making. So, there are patients who do tremendously well with upfront therapy, and really there's no strong, need necessarily for non-curative surgery. But if it is something that now for a year has been on the patient's mind again and again and again, and they've had a very good response, I have sent patients to see urologists, and many of these have done very well with the operation. Then I think it's very important that they understand beforehand in that setting that doesn't automatically mean that they're, not going back on systemic therapy, ever again, or that they're not done by then. They have to understand sort of the implications.
Yep.
I want to thank my colleagues, Martin Voss and Betsy Plimack, for this great review of first-line treatment and some of the issues surrounding first-line treatment in metastatic renal cell carcinoma.
Thank you.
Thank you, Brian.
Thank you very much, Dr. Plimack, Dr. Costello, and Dr. Voss for that excellent discussion, and thanks to you, the listeners, for joining us. Join us again in the next episode for a discussion on treatment approaches for second-line therapy and beyond. As a reminder, to view the full program, Practical Application of Immuno-Oncology in Renal Cell Carcinoma, and to download the slide set associated with this discussion from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.